10 days. So that it will be important when we try to extend the treatment to more patients who present later. For example, in this study that's published last year, it is not as high quality as the CHANCE trial because it's an open label trial and they use a different outcome. It's early recurrent stroke within the first, I think it's early deterioration in neurological function by NIHSS within the first 7 days. When you look at the study protocol, they keep on changing the primary outcome and so on. But anyway, they extend the minor stroke to moderate stroke, so they recruit patients with NIH up to 10. And then they also, they still with it, they treat the patients with a longer time window, 48 hours. The results is actually significant. There is less primary outcome without increasing bleeding risk. So the American Heart Association guideline actually said DAPT can be considered even up to 10 days after stroke. This at least provide, and then with higher stroke severity, this at least provides some support that not only minor stroke, maybe even up to NIHSS of 10 you might consider. What about lacunar stroke? We said in the SPSS trial, patients put on long-term DAPT actually have a higher bleeding risk. And in these minor stroke trials, a lot of patients are actually having lacunar stroke in etiology because if you do your studies, check the stroke pattern, they are actually lacunar stroke. Will they be harmed? It's actually not. First, the subgroup of the studies actually did not show that. And there's some evidence, for example, this is a Heidelberg cohort study that shows that if you, even if lacunar stroke, if they progress, if you put them on DAPT, they actually have better outcome. So up to now, from the trials, there are a lot of information, but there are also a lot of different considerations. For example, in the Chinese trial, they said we can give DAPT, but I think most of the investigators actually just loaded the clopidogrel without loading the aspirin. But clinically, it depends on whether your population has high bleeding risk. In Singapore, we actually loaded both with 300. And if in patients with high risk like precentral TIA or progressive stroke, we actually load the clopidogrel with 600. Durations, 21 days. Maximum you can consider 90 days, but these are mainly for really high risk patients with ICANN. TIA, what about TIA with lower ABCD2 score? Generally not, because if they are TIA with a low ABCD2 score, they might not even be TIA, they might be just TIA mimics, except they have other risk factors like large artery atherosclerosis, which they have shown in the SOS-TIA cohort that they actually have high risk, and also they included them in the TAIL study. Lacunar stroke, we said we probably should include. What about NIH stroke scale score more than 3 in TAILS, and in the TEMPEST trial, they actually include. Now we come to aspirin and ticagrelor. Ticagrelor is one drug that in combination with aspirin doesn't seem to increase the bleeding risk as much as prasugrel. So prasugrel and viropexa is actually have a black box warning not indicated for patients with a history of stroke, but ticagrelor, they went on to investigate. Unfortunately, if you use it as a single agent compared to aspirin, it didn't lead to significant decrease in recurrent stroke risk. But it seems that in the sub-study in Asian patients, it actually reached significance. So this is a drug that is maybe a bit better than clopidogrel, maybe better than aspirin. So sometimes in certain cases, you might consider using it, but of course, there's a higher cost. So they actually need to go back to do the DAPT trial, aspirin and ticagrelor versus aspirin. It actually shows more stroke prevention, but actually this time there's more bleeding. So when you consider CHANCE and TAILS, there's actually some overlap of the patients. Although TAILS included a little bit more severe stroke. So for minor stroke with NIH stroke scale score within 3 or TI with ABCs or more than 4 is actually covered by both trials. And it seems that in direct comparison, maybe aspirin and clopidogrel is preferred because of the lower bleeding risk. In patients that are not included in the CHANCE trial, that means NIH stroke scale score 4 to 5, or TIA or with extracranial and intracranial stenosis. then you can actually use both. But because there's also some evidence that these patients are actually included in the Artemis and Inspire trial, which we'll discuss later, maybe you can also consider aspirin and clopidogrel. But for patients who actually fail clopidogrel, or later on the chance to trial with clopidogrel resistance, then aspirin and ticagrelor might actually have more justification and more support. So chance to trial is a trial that randomized aspirin and ticagrelor versus aspirin and clopidogrel for 21 days in the same population, minor ischemic stroke or TIA. And in China, they are quite remarkable in that they have a point-of-care machine that can turn around, can have the results available within 90 minutes. So the patients come in within 90 minutes, they are randomized based on if they fulfill the criteria that they have an intermediate or heterozygous or homozygous loss of function gene. The stroke rate in this group of patients is actually reduced. Although there is some caveat because this CYP2C9 lead is not a perfect predictor of clopidogrel resistance because in the phase 2 study, the PRINCE study, in those patients with clopidogrel loss of function gene, with ticagrelor, the presence of platelet resistance is actually 10%. But without this treatment, the presence of platelet resistance is actually 34%. If the CYP2C9 lead is a perfect predictor of clopidogrel resistance, it should be 100% versus 0%. So it's a bit helpful, but it's not. So that's why the result, there's some interesting finding in the sub-study. It actually shows that the benefit is more in patients with small vessel disease without any significant benefit in large artery disease, which is actually contrary to our expectation. Now, I don't think we need to go into this in detail because ICAT is actually covered by Andre. We have some early studies that shows that if you give them DAPT in extracranial or intracranial artery disease, there's a finding that there's decreased transcranial embolic signal. And when you combine the two trials together, it actually suggests a decrease in recurrent stroke risk. Warfarin, we know that warfarin is not better than aspirin, and patients with more than 70% stenosis has a very high recurrent stroke risk, more than 20% a year. In the SAMPRESS trial, they have the aspirin clopidogrel treatment for 3 months, which becomes standard. The new thing is the INSPIRE trial, which they included patients with either 50% stenosis. The second inclusion criteria is a little bit soft. They said if you have stroke within a territory, they presume that there is ICAT in that territory. So they included those patients, and then the result was positive. So it's support that if you have 50% stenosis, you need to put them on 21 days of DAPT. But when you look at the response curve, after 21 days, there seems to be some rebound. So maybe 21 days is not enough. Maybe you still need somewhere between 21 days to 90 days. But for severe patients, then it's 90 days. I think I don't need, time is up, should not label the dicridolol or cilostazol. The only one thing is these drugs are good for long-term prevention, but for the dicridolol trial, the curves actually diverge after 3 to 6 months. So there's no short-term event, no short-term effects like the CHANCE trial or the TAILS trial. And and then there is a trial that actually used cilostazol and aspirin in Japan, the ADS trial. There's no effects within the first 14 days. So it's not to be considered as an alternative to CHANCE trial. Aspirin and clopidogrel for long-term prevention is also an option for atrial fibrillation. That was in the warfarin era. If the patients cannot take warfarin, DAPT is better than aspirin. But now we have NOACs, which is much better, lower risk of bleeding, much better tolerated. I don't think there's any point in most patients to consider aspirin and clopidogrel. Then the last is, I think, earlier on Henry has mentioned that TPA is not indicated for minor or disabling stroke. There's a Chinese trial, Aramis, that actually shows that in non-disabling stroke, they have some definition that the NIH score, they should not have more than 1 point in weakness, vision, and language, and so on. So whether it's really asymptomatic or non-disabling is difficult to tell, but there's actually no benefit in general. So I have a review article last year which actually summarized most of these points, so maybe if you're interested, you can actually read that. Thank you very much.